I've been a heart failure doctor, cardiologist for over 25 years, trained at McGill and Stanford University. My principal role has been to lead a large heart failure clinic whereby we see, several thousand patients living with heart failure. My time as a heart failure cardiologist, I've been involved in many clinical trials. And my particular interest at this point, having followed patients for many years, is to try to understand how we can predict patients who are living well with heart failure, with what we call low ejection fraction, how we can predict that they are decompensating and developing overt heart failure. So we're always looking for markers or predictors of the development of heart failure, of overt heart failure. And this is my particular research interest right now. I'm the program lead of a large biorepository called the Courtois Cardiovascular Biorepository. We have almost 4,000 participants entered in this biorepository who have what we call deep phenotyping. So we have a lot of information on them, labs, electrocardiograms, head, carotid, heart MRIs, exercise data, digital health data, many questionnaires. And we're using this data to try to better understand who develops heart disease and who remains healthy, but as well in patients who develop heart disease, who will respond to therapies and who will not respond to therapy. So it's really the focus of this is to really try to advance the concept of really personalized therapies. So we are creating signatures using all of this data, working with some AI partners. We are creating signatures to try to predict who will develop heart disease and which patients who already have heart disease will have more difficulties moving forward, to try to help to, prevent some of the difficulties that they may encounter along the way. Cough is not something we talk about very often in heart failure. We talk mostly about shortness of breath, and we use a term called orthopnea, which is shortness of breath lying down. Okay. And the reason that patients with heart failure have these symptoms is that they accumulate fluid in their lungs. The heart is just not able to either accommodate the blood or pump the blood forward. And so there's fluid that accumulates in the lungs, which we call pulmonary edema. Usually the symptom is shortness of breath or shortness of breath lying down, but cough is also one of the symptoms. And I do believe it is an important, probably underappreciated symptom of heart failure. Cough, the symptoms of heart failure are most commonly seen in people lying down, and people get very uncomfortable. They get this sense of congestion in their lungs when they lie down. And so cough is one of the symptoms that patients will complain about, cough lying down when they have heart failure. I'm particularly interested, and this is why it's what I find what the work that HIFE is doing is, I'm particularly interested to know if to document the frequency of cough in patients with overt heart failure. And in other words, I'd like to know when patients, in particular when patients are lying down and they are potentially starting to accumulate fluid in their lungs, sort of that early phase of decompensation where there's fluid accumulation in lungs, is there increased cough that one could detect to help predict that this decompensation is coming? So I'm very interested in the work that HIFE is doing in an ideal world, if we could predict a decompensation of heart failure, an accumulation of fluid in the lungs, we could detect it very early using cough as a biomarker. That could really change our approach to heart failure. What I would like to test is, patients living with heart failure, that is well compensated heart failure, in other words, there's not this fluid buildup in the lungs, if we can use cough to detect the early onset of this fluid accumulation in the lungs, so that one could intervene with diuretic medications before the fluid buildup in the lung becomes too high that it requires a hospitalization or a visit to the emergency room. Now, we have done and we have seen and we have reported on a few patients using our current biorepository and patients that are enrolled who are known to have heart failure. We have been able to show, this is anecdotal, this is just in a few patients, that there is more cough during the hospitalization with heart failure associated with symptoms of heart failure, physical exam of pulmonary edema, elevated JVP, as well as high NT-proBNP, a marker of volume retention, and that cough diminishes as the pulmonary edema is treated with a diuretic. So we have demonstrated that in an anecdotal fashion in patients with heart failure who are hospitalized. And ideally, we would do a large study to be able to replicate this and to be able to really show this in a population in a more definitive way. I would imagine a study whereby we take patients who are discharged from hospital after an acute decompensation, after an admission due to heart failure with pulmonary edema. We know that in those first 30 days after discharge, this is the highest risk period for reaccumulation of fluid in their lungs. And what I would like to be able to do moving forward is take those patients at baseline when they are discharged, monitor their cough, send them home with the HIFE technology, and monitor their cough over a period of the next 30 days. And we would be looking for patients who may start having cough again, especially cough lying down, and see if this predicts who will be turning up to the emergency room with overt heart failure. So this is a study that we'd like to do, hopefully in the near future. Now, it would be very helpful to have potentially ancillary, so other technologies as well. So, ideally, moving forward, this study would be done with the HIFE technology, looking at cough, assisted with other technologies that are looking at other biomarkers, so heart rate, saturation, blood pressure, heart rate variability. And there are technologies that could potentially do this. So that would be very exciting. And that's what hopefully the future holds for HIFE.